I'm going to spend a few minutes today talking about making some of this work happen and real from the perspective of a trade association, which is what we are at America's Essential Hospitals. So it's going to be a somewhat different take from what you've heard perhaps before. Give you a little bit of a sense of who we are. We have about 250, now probably close to 270 member hospitals who are dedicated to caring for the most vulnerable people in our communities. If you look at our membership, it would be places like Henry Ford, who's one of our members. In Chicago, it would be places including University of Illinois Chicago and Cook, and also University of Chicago, among others. And then we have many members who serve very large geographic areas, focusing on the most vulnerable, places like St. Luke's in Idaho, WVU system in West Virginia, or University of New Mexico, which serves both Albuquerque and the entire state. Our hospitals tend to have very high level of specialized services like trauma, burn, NICU, disaster response. They're virtually all teaching hospitals. Many are major academic medical centers. And they also distinguish themselves by having very large ambulatory networks that help them to reach out into the entire community. Now, let me talk about the patients who our hospitals serve, our members. Given who I mentioned who we are, it probably doesn't surprise you that they're very diverse. So when we look at our membership, on average, for our hospitals, most of their patients are going to be Black or Hispanic. For many of our members in places like, say, Elmhurst Hospital in Queens or the LA County system in Los Angeles, they have huge amounts of diversity. With literally dozens of languages being spoken within the walls of their clinics or hospital. Most of their patients are low income. On average, about 40% of our members' patients are Medicaid patients, and in some cases that's as high as 70 or 80%. In some of our hospitals in Texas, fully half don't have coverage. And while it's maybe hard to see here in this diagram, when you look at ethnicity, about 25% of the patients, their ethnicity is unknown in our hospitals. And that leads you to something which I think is really important for the American hospital industry to confront, and which we've tried to help it confront. That is that for most cases, perhaps in contrast to Henry Ford, which is truly a beacon, most hospitals in America don't really know who they're caring for. Don't really know the language, the race or ethnicity of many of their patients, and are far from being able to stratify their outcomes or quality by patient demographics. So we have a long ways to go. Recognizing that, a number of associations came together about 5 years ago under something called the National Call to Action to End Healthcare Disparities. Those include the American College of Healthcare Executives, ourselves, the Association of American Medical Colleges, or AAMC, the American Hospital Association, as well as the Catholic Health Association of America. And these 5 organizations have dedicated themselves to 3 big dots, 3 big goals. First, increasing the collection and use of race, ethnicity, and language data. Second, increasing cultural competency training in our member hospitals. And third, which I think has been the hardest, frankly, increasing diversity in governance and leadership. Those are the 3 things that these associations have pledged to do, and we are now literally going to our members, starting with the board members of our associations, and asking them to sign on to this as a pledge with quantifiable goals. And to not only do these things, but to set targets for themselves and to set where they want to be in, say, 5 years. I'll add to that that in our own association, we're doing this, but have gone beyond that to add gender as well. Because we are amazed at the paucity of women in positions of leadership, even in our own hospitals. And we think that's something that also needs to be urgently addressed. I should also mention that with us here today is Tomas Leon from the Institute for Diversity, the energetic new CEO, and his energy and efforts are going to be central to helping to make this vision come to reality. Now, among our members, we also decided to make this work real or implement it in another way. America's Essential Hospitals is a Partnership for Patients contractor. So we have a hospital engagement network, and we're one of the 25 or so or 26 entities that do that. And we have a couple of dozen of our large members involved with this. And Patrick Conway and others spoke about this today. In our own network, we have seen really breathtaking improvements in safety and quality. We've seen thousands of harmful events avoided. Just don't take our word for this. This has been externally evaluated by folks working for CMS independently. And we've seen tens of millions of dollars in cost savings. When we started this work several years ago, when the partnership was first launched, we viewed it as a quality and safety enterprise, but also as perhaps the best opportunity we'll have in a generation to address equity in hospitals. So from the get-go, in our network, we made equity and reducing disparities a central core and tenet of the work of this network. We have our hospitals not only doing this work on quality and safety, we have them collecting patient race, ethnicity, and language data, as well as other demographic data, stratifying their performance and outcomes by this data, finding disparities in some cases, and actually working to address that. We believe that the whole area of equity has to be hardwired into the clinical quality enterprise as the way you're hearing about it today on this panel. Otherwise, it will not be something tangible for the leaders of America's health systems. And we cannot let them off the hook, frankly, in that regard. So while we did this work, and very important work, it had also a very important outcome or product. As we worked with our hospitals, we realized there was no easy, cost-effective way to train the hundreds, in some systems, literally hundreds of patient registration clerks who needed to be trained to talk to patients at registration and collect race, ethnicity, and language data. And this is work that many of us have been involved with for years, but it's still somewhat cumbersome. We thought that one of the good products of this work would be to create a module, create an online training module, which we now have deployed and begun to deploy in some of our hospitals in our membership, which could actually be uploaded into literally every hospital in America's learning management system to allow them to briefly and succinctly train their registration clerks on how to collect this data and literally get certified on it through an online tutorial and self-examination. We're now deploying this. It's, I think, in place now in about 10 hospitals. And we're planning with other partners to begin this deployment nationally to more hospitals across the country. We believe it's a low-cost way to do this work, and we think it will remove the excuses that are often out there when folks say, oh, we'd love to do this, but it takes so much time, and integrating it into our learning system, into our EHR and everything else, we just have other priorities, we'll get to it later. We'd like to take those excuses away, take those barriers down, and we think this will be an important way to do that. So stay tuned for this as we begin to roll it out more across the country, hopefully, in the months ahead. We also think that a lot of this work requires some action on the policy level. And you heard some of this alluded to this morning in some of the opening presentations. We think that the work of equity is absolutely critical, not just for essential hospitals, but for every healthcare provider in America, given the way our nation has changed demographically and where folks live today in our country. We also think there needs to be a policy response to this as well in other ways, and Marshall talked about this. We do believe that for some quality measures, and especially for some of the payment incentive systems that are now being put into place, there needs to be risk adjustment for a patient's socio-demographic status. We believe without that, we risk essentially penalizing those institutions who care for the most at-risk patients. And we send a message to the marketplace that the best way to avoid a quality penalty, and frankly to increase reimbursement, is to frankly avoid certain communities across America. And that would be the worst possible message to send. Now, many of us are working on this. There's been legislation introduced on this in the hospital readmissions program. And I'm hopeful we'll see some movement both legislatively as well as in the National Quality Forum on this in the months ahead. But I think it's a bigger issue than the readmissions program. As we move towards a different set or different way of forms of payment, ACOs, bundled measures, episode of care, all these things in some way download risk onto new communities, onto different sets of providers, And those models have to take into account the patients who those providers care for and the communities they serve. So I think this is going to become a huge issue in the years ahead as these payment models begin to proliferate. And unless we begin to think about this now proactively, we have a great danger of doing some very unintended harm, but true harm nonetheless, if we don't take account of some of these things. Finally, I thought it was great this morning when I think it was Cara who referenced where we've been as a nation 50 years ago and how, and I got to tell you, many people in my office didn't realize this, some of my younger staff, they didn't realize that what desegregated American hospitals was Medicare. Medicare conditions of participation. In my own lifetime, and I don't think I'm that old, but you may feel differently, we've seen great change. And we've come from a place where we saw signs like that in some of our hospitals, where that nothing could be furthest from our mind today, perhaps in many ways. So while I think we're very frustrated very often, and we're frustrated at the pace of change, and I am frustrated as well, a lot of change has happened in 50 years. And I think we need to celebrate that today as well, because most of that change, the great majority, has been very good. And I think the things that will come out of the Affordable Care Act will be equally as good as we look back 50 years from now. Thank you.